Welcome, everyone. We are so glad that you are with us. We are just opening up the webinar, so folks are streaming in as I speak. We're very happy to have you here to talk about maternal and child health. And we have a great session planned for you today. So if you would like to drop your name and where you're from in the chat, that'll help us get to know each other a little bit better. Jonathan, if we could move to the next slide, just so people know that they're in the right place. Yes, you're here. Welcome to the third webinar in the series of the Whole Child, Whole Families, Whole Systems webinar series. This particular webinar is focusing on maternal and child health and mental well-being and the cross-sector work that is happening. Today we're focusing on Guilford County, so a community level initiative that is doing some great work in terms of connecting systems together to better serve pregnant individuals and their babies. So welcome. People are still joining us. I see you putting your name and your locations in the chat. That's awesome. Welcome, welcome. We're going to get started in 30 seconds. Before we go any further, we're going to introduce our Spanish and we also have American Sign Language interpreters on the webinar today. So Valentina, if you'd like to introduce yourself and talk about what you'll be doing for us today.
Absolutely. Thank you very much, Michelle. Hi, everyone. Hola a todos, a todas y a todos. My name is Valentina, and I'm here on behalf of Community Language Cooperative, and I am here to provide and guarantee your commitment to language justice. Language justice is a type of simultaneous interpretation that seeks to create spaces in which no one language is dominant, spaces in which everyone can participate in the language of their heart. So to achieve this objective, we'll be using Zoom's interpretation feature. What you will see in a couple of minutes is that a new little button that looks like a globe will appear on the bottom bar of your screen. On that same bar where you currently have the buttons for the microphone, for the video, for the chat, etc. It'll be towards your right hand. Once you see this new little button come up, go ahead and click on it and select either English or Spanish as both the language that you will be listening into and speaking into. If you are joining the meeting on a phone or on a tablet, you will find the same options for interpretation by clicking on the button with the three little dots on the lower right-hand corner of your screen. This button reads More. Hola nuevamente, mi nombre es Valentina y estoy aquí por parte de Community Language Cooperative y estoy aquí para ofrecerles y garantizar su compromiso con la justicia del lenguaje. La justicia del lenguaje es un tipo de interpretación simultánea que busca crear espacios en los que no domine ningún idioma, espacios en los que todos puedan participar en el idioma de su corazón. Para lograr este objetivo vamos a utilizar la función de interpretación de Zoom. Lo que verán en un par de minutitos es que aparecerá un nuevo botón, que parece un globo terráqueo, en la barra inferior de su pantalla. En esa misma barra, donde ahorita tiene los botones para el micrófono, para el video, para el chat, etc. Va a estar hacia su mano derecha. Una vez que vean este botoncito aparecer, haga clic en él y seleccione inglés o español como el idioma en el que desea escuchar y participar. Si usted está en esta sesión por medio de una tableta o de un teléfono, encontrará las mismas opciones para la interpretación haciendo clic en el botón que tiene 3 puntitos en la esquina inferior derecha de su pantalla. Ese botón dirá More o Más. A quick reminder for those of you that do prefer to use English during this meeting, Spanish is 20 to 25% longer than English, so please keep this in mind and keep a conversational pace when you participate. Everyone must select a language channel. Only those of you that are fully bilingual can choose to ignore the service. If you have any questions or any issues whatsoever with this technology, please let the whole group know by means of the chat box so that we can work together to address them. Un breve recordatorio es que la interpretación es simultánea, entonces cuando participe mantenga un ritmo de conversación. Si tiene alguna pregunta o algún problema con esta tecnología, por favor comuníqueselo al grupo completo a través del chat para que lo podamos resolver en conjunto. Muchas gracias por tenerme por acá. Vamos a activar los canales de interpretación ahora. Thank you so much for having me here. We can go ahead and start the interpretation channels now.
Okay, so everyone has, if you've selected that globe and selected your preferred language, either American Sign Language, English, or Spanish, we should be all set to go. So I'm going to move on to the next slide, if you will, Jonathan.
All right, I'll kick it off.
Gazi, this is you, right?
It is.
All right.
Hello, everybody. I'm Ngozi Lawal, and really pleased to be with you here today. Some of you have been in on a few of our other webinars, and so these objectives will be familiar to you. But for those of you who are joining us for the first time, we want you to know that this is the Whole Child, Whole Family, Whole Systems webinar series. And so there are themes that we are covering across the series. This is our third webinar in the series. There are 9 of them, so we hope that you will stay with us. And in the webinar series, these are the themes that we are covering, and these themes will pop up today for you as you listen to the conversation. So we will be thinking about a whole system approach. We'll be thinking about what are the key challenges that keeps those of us who work in the child and family service sectors from working collaboratively and working efficiently and effectively. We want to know how we can support you with thinking about strategies for system integration, working more cohesively and making sure that families are receiving services in a way that makes sense and is not siloed and segmented. We are centering family voices and equity. We are beginning this conversation and all of our conversations with the voice of families, because that is why we do our work. And we're thinking about how we bring data into this conversation to inform how we do what we do and how to do it better. Today, you'll be hearing from a real world example from Guilford County, North Carolina, so that you can think about what perhaps are actionable strategies for your own community or your own state. And certainly these presenters will be available if you reach out to them afterwards, if you want to dig a little bit deeper, if you want to get more, roll up your sleeves and think more about strategies. And then finally, we want to help you think about how to promote this work, not just for a season, but for the long haul. So sustainability is a really important feature of these conversations in the webinar series. Next slide, please. So today's objectives are really lengthy because we have a lot of perspectives, and we're really excited to bring all of these voices together. I won't read all of these for you, but I do want to just spotlight a few of the objectives that we want you all to benefit from. So we'll have a conversation that will bring you into a mom's experience and what it's like to give birth in a place that lacks obstetric care, particularly in a rural area, and what it's like to be in a maternity care desert. We'll also hear from another mom who will speak about birth outcomes and how birth outcomes can be shaped by systemic disparities. And then on the flip side, thinking about how we shift the conversation from systemic disparities to joy, abundance, and dignity as the outcomes that we're really trying to achieve as we think about maternal and child health outcomes. And then we're going to be hearing from other speakers who will talk to us about what is some of the different actions that we need at the different levels. What are the different levers that we can all harness in order to make our work better and to make the experiences for children and mothers and parents at large better. Next slide, please. So I'm really excited to bring together this really powerful group of presenters whose experience and professional expertise and community leadership really embody the vision of thriving families and a strong system of support. We're going to begin with Leah Lapine, a dedicated patient family partner with Mama's Voices. Leah is not only a fierce advocate, but also a super mom who bravely navigated the complexities of our maternal health system during her own journey. Her story reminds us why centering the voices of patients and families is essential to transforming care. Next, we welcome Dr. Melissa Franklin, who's the founder and CEO of Growth Mindset Communications. Dr. Franklin is a national maternal health leader and mother whose personal experiences navigating the system have fueled her passion for elevating community voice and equity in maternal health. And her perspective bridges storytelling, strategy, and lived experience. We're also joined by Dr. Jasmine Beam, Director of Public Health Strategy and Innovation at the Association of Maternal and Child Health Programs, also known as AMCHIP. And as a leader at a national organization dedicated to advancing maternal and child health, Dr. Bim brings a strategic lens to the broader landscape of programs and policies shaping outcomes for the country. And then finally, from North Carolina, we're excited to feature Dr. Danielle DeShazer Tab from Roots to Ready at Ready for School, Ready for Life, and Brianna Grant, who's the perinatal health manager at Every Baby Guilford, which is at the Guilford County Department of Health and Human Services. And so these two dynamic leaders represent a collaborative and innovative approach to uplift maternal and child health in their state. So today's speakers bring a unique, powerful voice to this conversation, and together they help us envision where maternal and child health and mental well-being are really foundational to realizing thriving communities. So let's dig in and go ahead and get started.
So I just realized that I was so excited to get the webinar started that I didn't tell you who I was. So let me tell you just briefly, my name is Michelle Adkins, and I work with the Prenatal to 3 Capacity Building Hub, which is a project at Built, and it's funded by the Pritzker Children's Initiative. So that's who I am, in case you were wondering. We have just an incredible group of people who have registered for this webinar. Over 750 people have registered from 47 states, the District of Columbia, and the US Virgin Islands. And we're excited to have you here. You're from state agencies, you're from child and family serving organizations and nonprofits, early childhood coalitions, child care resource and referral agencies. You can see the list there. We've got a broad range of folks that have registered for this, and we hope they're actually attending the webinar, and we look forward to hearing the conversation that you have in the chat and with the presenters. Next slide. So this tells you a little bit about deeper about who you are. These are the titles that you have given us as you registered. We have parent and youth ambassadors. We have early childhood mental health folks. We have community-based prevention consultants. We have community health workers and RNs and social workers and policy managers and parenting educator and family coaches and program coordinators. So we've got lots of different folks on the webinar, and we're so glad that you have joined us today. Next slide. And so it is my honor to now introduce Leah Lapine, who is going to tell us about her journey through pregnancy and birth. Leah, it's all you. It's all you now.
Thank you for your kind introduction and the opportunity to speak here today. I'll ask that you bear with me. This is my first time to share our story with such a public audience. I'm not usually one that's comfortable with public speaking. You're far more likely to see me quietly behind the scenes doing work. So you might ask why I would break out of my comfort zone and tell our story. It's because I get caught in the day-to-day and I don't maybe think about it much, but if I pause for just a moment and think back about this time, I remember the fear I felt trying to make it to maternity care while hemorrhaging, the distress I felt while staying away from family for almost 7 weeks because I lived too far from maternity care to return home safely. It was during those long hours and days and weeks that I resolved that this could not be the new norm for our community. Pregnancy and delivery is about as universal an experience as it comes. How is it that we seem to be moving backwards in regards to the availability of the care necessary to do this safely? As you can see here in the picture, I'm a mother of 12 children. Obviously, the perinatal period has been a near constant part of the last 2 decades of my life. You might think that birth would become routine at some point, but in fact, every delivery is different. Some were near perfectly smooth, some a bit more tricky, and some had serious complications. The thing they all had in common was that I was able to receive expert obstetric care close to my rural home. That was until my last pregnancy with our youngest daughter, Daisy. Daisy's pregnancy was uneventful. It was full of what seemed like constant testing and appointments, because when you're 44-year-old expectant mother and have 11 children already, you make everybody nervous. It was uneventful until one morning I woke up to realize my pajamas were completely soaked. I immediately thought that my water had broken at some point in the night, and since I was only 33 weeks along, I knew this was an urgent turn of events. My horror increased when I pulled back the blanket to see that I was lying in a pool of blood, because just less than a month earlier, our local OB department had closed, leaving us over 2 hours from high-level obstetric and infant care. Since learning of the OB closure, I'd played through these scenarios in my mind, not only as preparing for it as a local critical care staff nurse, but also as a patient. I knew there would be these situations that would occur, but I hoped kind of selfishly, like everyone else does, it wouldn't directly involve me or someone I loved. I didn't even take time to put shoes on that morning. We both literally ran for our car, leaving our older children attending to the younger ones while their grandparents were en route. And my husband began driving as safe as possible towards a destination that was far beyond what was safe or advisable with my symptoms. I rode laying on my left side, feeling the bleeding continue. And I, at that moment, felt I was a nurse without the ability to monitor myself or my baby. But I knew that stopping at a smaller local emergency department would only delay the care my baby and I truly needed. It was over 30 minutes before I felt Daisy move for the first time. A little kick, but we sent up shouts of praise, knowing that she was still with us. Our route took us through congested intercity traffic, and we both took turns praying for protection and open roads. We had called ahead, and the team was prepared for our arrival. I was diagnosed with a partial placental abruption, and with treatment, they were able to stabilize me and get the bleeding slowed. Thankfully, the ultrasound showed a healthy baby that didn't show any signs of distress. And my body was trying to stop the bleeding the only way it knew, by uterine contractions. The doctors were certain we would need a C-section soon, and the NICU nurses, we were put in a delivery room, and the NICU nurses brought in the isolette, and I had to sign all the paperwork. I've had 4 other NICU babies, and I wanted nothing more than a healthy full-term baby this time. Amazingly, those contractions and the interventions did their job, and the bleeding slowed and allowed the doctors to continue monitoring me rather than delivering my baby at 33 weeks. I had another episode of heavy bleeding 2 days later, followed by more contractions. When the bleeding slowed again, the doctors told me that I wouldn't be allowed to go home before delivery, due to the lack of emergency OB care that was available there. I was devastated at the at the thought of being so far from home and family for a few weeks. But at that time, they planned on delivering me at 35 weeks in hopes of a healthy baby and to avoid any further complications for me. You can go ahead and change to the next slide. I settled into what I thought would be a couple weeks of bed rest in the hospital. After several days with no further bleeding, I was allowed to resume normal activity in the hospital, and I walked miles around the halls every day. But there was, just to make sure there wasn't going to be any further bleeding that would necessitate an early delivery. With no more bleeding, they gave me the news that they couldn't justify delivering my baby early, and they couldn't justify a continued hospital stay. But the risks were too high for me to return home. I would need to find a place to stay close to the hospital in case of emergency. We had no family that lived close there, and even the Ronald McDonald House wasn't an option, because as the patient there, I would have to have an adult stay with me, and all my adult family members were either taking care of my children at home or working. So our only option was to check into a hotel that was a 2-minute walk from the labor and delivery department. During that time, I felt very unseen by my providers. I would walk across the street for my weekly high-risk appointment and testing and ultrasound. They would greet me with a head shake and a laugh. And they would say, "Hey, are you still hanging out in that hotel? I bet it's like a mini mom vacation or something." I would politely smile, but inwardly I would cringe. I would ask if there was any other option or they'd come up with any other ideas, and they would say no. I know they didn't have any ill intent. They just didn't seem to understand what it was like to be used to spending my days actively meeting the needs of my children and patients back home, only to be removed from it all and sit and wonder about those important issues that were falling through the cracks back at home. Change to slide 3, please. This is a photo of my only family time during my stay at the hospital. My husband would drive the whole crew down, and we would enjoy sandwiches in my room and swimming in the hotel pool every Sunday afternoon. It was a happy time, but I dealt with many emotions. On one hand, I was so thankful that I could continue to let the baby develop and hopefully avoid a NICU stay and possible complications. But on the other hand, I was absolutely broken with the knowledge that I might possibly need to spend another 4 to 5 weeks away from my 11 older children and husband. It was a lonely time that was spent by myself. I had a lot of worries about the extended absence I had from work, the care of my children, including 2 special needs children at home, and significant financial worries due to having to pay out of pocket to live in a hotel. I considered all kinds of ways to make money somehow while I was away. One of those is I thought maybe I could get on as a housekeeper there in the hotel and work for my room and board. All these ideas were wisely shot down by my husband because of the still present risk of an early delivery. I did not want to come this far only to deliver early and require a long NICU stay. Because of my earlier NICU experiences, I had prayed from the beginning, asking the Lord to allow this pregnancy to go full term. Little did I know what I was asking for all along. You can go ahead and do slide 4. After almost 5 weeks of hotel solitary confinement and far too much binging on true crime shows, which, by the way, is not a good idea when you're staying alone in a downtown hotel, little Daisy quickly made her arrival at 39 weeks, with my husband rushing back from home with only 3 minutes to spare before she was delivered. In total, I spent almost 7 weeks away from home, but I was able to bring my healthy 8-pound baby home to join our family a mere 24 hours after delivery. We all agreed she was worth every bit of all that difficulty. I am definitely not the only one with a story to share from our community from the last year and a half. Some have involved far more sacrifice, and some have had devastating outcomes. All these stories aren't narrow in their consequences, only involving the mom and the baby. They have a ripple effect, changing whole families and communities. Even before I was personally affected by a lack of maternity care in our rural area, I felt the weight of concern as a healthcare provider. I feel trepidation in regards to any further pregnancies for myself and my loved ones in the area. It cast a shadow on what should only be a joyous time. As much as I would like to wave my magic wand and reopen the maternity department where I delivered my older children, where I was delivered, and where many previous generations were delivered in my rural Missouri town, the barriers that caused its closure still exist. I know I have no way of fixing this problem on my own. My hope is that by being vulnerable and sharing my story, that I can bring awareness to the difficulties that are faced by families in maternity deserts. I want to use the desperation that I felt to spur on a positive change for my daughters' and granddaughters' future. Thank you very much for letting me share.
Thank you so much, Leah. What a harrowing story that you have, and so happy that Daisy came into the world fully cooked, as you might say. And again, thank you for being vulnerable. And it is an important story to hear, particularly around care deserts. So thank you very much. Now we're going to hear from Dr. Melissa Franklin, who has a different story to tell but one that is just as harrowing and scary as Leah's. So Dr. Franklin, I'm going to let you take it from here.
Thank you so much. And thank you, Leah, for your story. I'm in love with Daisy. Oh my gosh. And your beautiful family. Thank you for being vulnerable and for using that as a platform to make change for other mamas. And thank you all for the opportunity to share my story today. It's just a tremendous honor, and similar to Leah, just hope that my being vulnerable and sharing will have an impact. This slide is just like a collage about me, and it'll be relevant to my story. I'm here as a daughter of Ray and Margaret, first gen college grad with a doctorate from the school that my father was recruited to, had dreamt of attending, but couldn't because he was drafted to serve in Vietnam. That service resulted in the exposure to Agent Orange, which eventually contributed to his death the year my oldest daughter was born. I come to you as a Black woman born through a labor that was induced by a sudden and shocking crisis that my mother experienced. A mother of two beautiful, confident, vibrant, wonderful young women, born 3 years apart and 3 months early, both of them. I come to you as someone who nearly did not survive delivering my second child, a warrior who carries wounds of an emergency C-section, cancer surgery, and most recently, open heart surgery. But that has fueled me to be a system stretcher, a team builder, a dancer, a little bit of a DJ who got pulled into the work when I left an upper league mobile corporate job after losing 400 colleagues in 9/11, who grew up in a Black family with connections to many cultures and enjoyed that. A South Los Angeles resident. And I have to say that I've seen my fair share of disparity. It has been woven throughout my life like a rough thread and a beautiful garment. It became my vocation when I was tasked to listen to accounts of over 110 Black women and found that we had the same experiences in childbirth, that my experiences didn't make me special. It was actually the norm. And we'll talk more about it next slide. This is where it all began. To look at this picture, you didn't think all that would happen, right? That my dad was fresh from Vietnam, or that my mom, fresh from losing her mother to cancer, both living in the segregated South and its harshness, or that me looking so cute in the center there was born in that sudden and shocking, horrible moment in my mother's life. What you see is love and closeness and joy. And that is actually kind of the theme we'll get into with my story. That's how I frame my story. Next slide. Again, pictures of my parents and my siblings and I, my happy family. You wouldn't see all that disparity again in this picture, but in this picture, there are three individuals who survived a cancer diagnosis. One individual who died of a heart attack, another individual, one individual, two who had heart surgery, three who had have a rare immune disease, right? And because of that, because I grew up like around a lot of health stuff, I tried to do all the things, eat right, exercise, maintain a healthy weight, go to my care appointments. And when I became pregnant, same, attended all my prenatal appointments, took folic acid like it was going out of style, educated myself on childbirth, ate well, and also had all the helpful things, right? And avoided the non-helpful things like smoking or other risky behaviors, and then did the helpful things. Like I said, attend my prenatal appointments, maintain a healthy weight, had a committed partner, a job at that point, an MBA. So all the things that on paper should look like this story was about to happen, this picture of my family and I. Next slide. Yet my outcome was not the pregnancy or the birth that I dreamt of. And I wanted to say in the beginning, and I'm sorry for not saying it, if this is you, right? Because though we are in this work, many of us are of this work as well. If this is your story, I'm sorry, I connect with you. I'm working to change it along with Leah. Please take care of yourself as we tell our stories and talk about this subject. Both my children, as I mentioned, were born 3 months premature. My oldest had heart surgery at 9 days old, and then a massive back surgery later in life due to a complication from that heart surgery. My youngest almost died twice in the NICU and took years to catch up. I had to actually leave work because she wasn't accepted by the regional center to provide occupational health support. And so I became that support. I was her PT therapist along with her doctor. There's so much that I would have wished could have happened and it did not. And I have to tell you that it's incredibly excruciating to leave the hospital without your child, to go back every day and leave again. And again, like I said, I thought I was special, actually in a way that was really shameful. I carried a lot of shame and embarrassment that I had this experience and really spent way too much time trying to figure out what I did wrong. And then one day when I had the opportunity to become a Pritzker Fellow and analyze this issue within our county, where Black women die at 4 times the rate of any other race, and Black babies die at 3 times the rate of any other race, that I realized that this phenomenon, or this thing that I thought was special or unique about me, really wasn't, and that for many the outcome was much worse. And then that shame really melted into resolve to make a change, into a resolve of seeing forward joy and abundance and health for all of our families in our communities, and really push and stretch our systems to lean into the promise of health and well-being that this country and our work collectively hold. There are a lot of things that I would have, that I wished I would have had. I definitely would have needed an OB, like that was a given. Like I wouldn't not have that, but I would have also had a doula. I would have pressed when my provider said I can do bed rest at home. It would not approve my staying in the hospital during the duration of my pregnancy. I would have pressed with when my provider told me that just because I had a previous premature delivery didn't mean that I was at risk for another, which was completely not true, the data shows. Some things did work out. Thankfully, I had a village. I was a home visiting client. And it took that home visitor quite a bit of work, right, to encourage me to accept her to my home and into my life and to my recovery from my first child, and did the visits before my child even came home from the hospital. And then again, when I had my second daughter, also a preemie, the same, was there with me. I had my church, my family, but it was incredibly difficult and heartbreaking. The only thing worse than having to leave your baby at the hospital and coming back each day only to leave them again is leaving the hospital and not having a baby to come back to, or your baby leaving the hospital without you to come back to. And unfortunately, that happens way too much in our country and my county as well. Part of the issue is these are maybe interventions that you all have posited, you have developed, you have implemented them, you're supporting them, you're creating policy around them. I'm not so much talking about what as the how we do our work. Many of you know about p-values and confidence limits and confidence levels and those data analysis measures that we use to speak to probability of something being not a coincidence, either a problem or an intervention. They're helpful, but they're incomplete. And it's understandable exploring a problem or solution like this, of this magnitude across a population, inevitably has some uncertainty to it. It doesn't negate the value of it. However, the issue is not the p-value or confidence limits, right? Or how we analyze what data we analyze it. It's, again, the how and what evidence we value among others, right? That data, often including birth and death records, important data points, are years old. But the story of the people that are experiencing this disparity, Leah's story and so many like hers in her community, are my story and others like me in my community, their data too, right? But they're not treated as valued. They're the punctuation mark and not the sentence. And really my hope is from all this work and my story is that our voices are the sentence, because we've said what problems we need to address, and across the board, access, respectful care that's person-centered, humane care, culturally affirming care, community affirming care, quality care, stress addressing care, context supporting care, acknowledging the context that individuals live in, fostering a village of support around folks, and then addressing economic hardship and injustice and those things that we know make things harder for positive birth outcomes. However, I'm willing to wait 10 years on a longitudinal study to prove to us that doulas, caring doctors, and midwives have a positive impact on birth outcomes, and right at our fingertips and in our voices are the actual stories that tell us what can work, what's hopeful, what's positive. We've also heard enough from providers who are stretched with not enough time, high pressure environments, pandemic trauma, exhaustion, and burnout. Yet there's so much that could be done that hasn't been done to address that, right? So these are all tall orders. I get it. What I'm saying is that we've investigated the heck out of the problem. I think we know it and we feel it and we see it and we're activated by it. But our conceptual frame, so to speak, has been off. We look for survival as a solution, as the outcome, as the end result. I survived my birth experience. My children survived their birth experiences, but I can't say that we thrived through it. I cannot say that it was wonderful or positive, or that I didn't have to deal with the physical and mental and emotional repercussions of that. But I survived, right? And so by all intents and purposes, for many, that's an acceptable outcome. And I'm stretching us or encouraging us to not think of it that way, to see joy and abundance and fullness of life as the ultimate outcome. We may have adopted this individually, like that's our frame. I'm also challenging us all in the work to adopt it collectively. We've studied the problem quite a bit, but we see the problem every day, right? That it's not necessarily just the behavior of a person, right? It's how the system is working together and the system's expectation of what is good, of what is healthful, right? We get to see the pieces of the problem in full view, but also the beauty and abundance brought forth through our daily work, through our relationships, the village that we've fostered and benefit from. What would it look like if that is how we measure success or change? What if the outcome of our work was joy, abundance, thriving, vibrancy? I think that does not leave out healthful births, full-term births, pregnancies that result in both the mother or parent and the baby surviving. I think it includes that. What if our conceptual frame or data collection, our analyses, or how we look at interventions all sought that as our barometer of that we're getting there. We'd still track disparity data, but where we head with it would change. I draw on Leah's story again. Technically, she had access, right, to a hospital, but was it a helpful access, helpful, stress-free, joyful, enabled her to enjoy her family every day, the things that brought her joy as she was waiting for her baby to come full term? And so that's, really what I hope is the result of my sharing the story. It feels like it was a million years ago that I had both my children. They are now 15 and 18. My 18-year-old is about to head out to college. My 15-year-old is doing great as well. It has been a tough journey, but a beautiful one. One thing that being around so much health disparity in my life and in my family, it really has given me a heart for seeing joy and abundance even through it all. And I really do believe that is something that we can seek to come alive in our interventions and our practices and our system mapping and our logic models, right? That we don't have to wait for the helpful things, right? The maternal mortality review, the infant mortality review, the longitudinal study proving that certain interventions are helpful. Those are good, and we can still honor them, but we don't have to wait for that to take the steps that really honor the voices of the people that have been impacted by this tragedy of our maternal health system that we have today. Next slide. It starts with valuing outcomes beyond simple survival. This is a picture of my two daughters the day my youngest came home. And in a lot of ways, at least for a moment, like the pain and the struggle melted just to see my children united for the first time, meeting each other for the first time, and their bond remains close to this day. It represents the very joy and abundance that my hope is that we are all able to establish as outcomes, but all as our expectation for the communities that we serve. I believe our belief in that is actually possible for the communities that we serve. So as we analyze our systems and orgs and the programs to see that if that expectation is actually present and fostered in our work. And so with that, I close. I just want to thank you for your time and for listening to my story and also my hopes for our work and my challenge to our systems. And it's a challenge to me too, because I work in these systems as well, for joy, abundance, thriving, and well-being to be what we aspire to for our communities, but also what we believe can actually be effectuated in our communities together.
Dr. Franklin, thank you so much for sharing your deeply personal and moving story. Your words and Leah's words truly ground us in why we do this work. It's really why we're here. So you are reminding us what is at stake, and we are so grateful to both of you for your openness and your voice. Let's call on Dr. Bim to transition us to help ground the conversation and give us a more national perspective on maternal and child health. Dr. Bim?
Thank you so much. Good afternoon. I'm Dr. Jasmine Bim. It's really nice to be with you all this afternoon. And then, as Ngozi already mentioned, I'll be discussing maternal and child health and mental health from a national perspective. Next slide. Excuse me. The previous speakers, Dr. Franklin and Leah, wow, they shared their personal and very powerful stories with us. I have to catch my breath listening to those stories because of how impactful they were. I have to say, no individual journey needs to be validated, but a look at the national statistics regarding maternal mental health paints an unfortunate picture. Maternal mental health disorders like postpartum depression affect about 600,000 mothers annually, which is about 20% of births. Almost half of these cases are undiagnosed, and so many more women are affected. On top of that, about 75% of women affected do not receive necessary treatment. This lack of addressing maternal mental health issues also has impacts beyond individuals and families, with costs estimated at approximately $14.2 billion a year. Next slide. Last year, the Policy Center for Maternal Mental Health, in collaboration with the George Washington University, published maternal mental health state report cards. The 2024 maternal mental health state report cards include 18 measures that are divided into 3 key domains, one being providers and programs, screening requirements and reimbursement, insurance coverage and payment. Using those measures, 29 states, yes, 29 states received Ds and Fs. I don't think we're really surprised by that, but that's unfortunate that we're not surprised by that. But what was driving those poor grades? Well, states don't have enough therapists and psychiatrists with specialties in maternal mental health disorders. States lack maternal mental health treatment programs and community-based maternal mental health resources. States do not require providers to screen for maternal mental health disorders. States do not hold health plans to quality standards regarding maternal mental health services. Next slide. So now let's back up a bit to discuss maternal and child health in general. As the U.S. Department of Health and Human Services has noted, maternal well-being affects the health of future generations. Whether or not mothers have access to adequate health care can have a substantial impact on an entire community. And we heard from the stories earlier. A mom had to be away from her children for several weeks. That has substantial impact on not just her as an individual, but 11 other people. Next slide. So with that, so that we're on the same page here, let me just go back to the basics and make sure that we understand, what maternal and child health refers to. And so the CDC has referred to it as women's health and well-being during pregnancy, childbirth, and postpartum after childbirth. Additionally, the WHO, which is the World Health Organization, also emphasizes each stage should be a positive experience, ensuring women and their babies reach their full potential for health and well-being. Like Dr. Melissa Franklin said earlier, that thriving aspect is really important in terms of the WHO definition, and something that we should all be focused on, that thriving in abundance. Next slide. Key indicators that let us know how the globe, our country, states, or localities are doing with respect to maternal health are maternal mortality ratio, prenatal and postnatal care access, skilled birth attendance, and postpartum care and outcomes. Related to the discussion earlier on mental health, the healthcare and support provided to a mother from immediately after birth to the first 6 weeks postpartum is a key indicator. And this includes mental health support, which is often overlooked. Good postpartum care can help detect and manage complications, such as postpartum hemorrhage or depression. So we really need to remember that when we're talking about postpartum care, it's not just the traditional medical things, but also mental health support. Next slide. In terms of maternal mortality, which is another key indicator, one that we often hear about frequently because it is so important, the US, compared to other developed countries, continues to have a high maternal death rate, with disparities by race. You'll note there the rate for the US. The bar next to it is the rate for Black individuals in the US. We'll get to that in a second. Next slide. So while there has been a slight dip in the maternal mortality rate in the latest measured years, disparities by race still persist, as you can see kind of clearly here. Next slide. Moving to another key indicator, infant mortality. The rate for the US overall is approximately 5.6 deaths per 1,000 live births. If you look at the graph here, you can see differences by state, with what some might see and refer to as geographic patterns. For example, the Southeast has higher rates of infant mortality. And so it's important to kind of take into account these geographic and regional patterns when we're assessing these outcomes. Next slide. So many factors contribute to poor maternal and child health outcomes. It's not one thing that is causing these poor outcomes. For example, socioeconomic factors, lower income, reduced education levels, and inadequate housing contribute significantly to poor health outcomes for mothers and children. Families facing economic challenges are more likely to experience food insecurity, limited access to healthcare, and higher levels of stress, all which negatively impact maternal and child health. Healthcare access and quality, as Leah mentioned earlier, rural communities or low-income communities tend to have fewer healthcare providers, particularly specialists like obstetricians and pediatricians, limiting timely care. Variability in healthcare quality further exacerbates disparities, as mothers and children in underserved areas may receive care that does not meet evidence-based standards. Racial and ethnic inequities contribute as well. These disparities are driven by a mix of factors, including historical and systemic implicit bias in healthcare and the cumulative impacts of discrimination. Research has shown, for example, that Black women in the US are more likely to experience severe pregnancy complications and mortality compared to white women, regardless of income or education level. Then we have the social determinants of health. Poor neighborhood conditions, exposure to environmental toxins, and lack of safe recreational spaces can really adversely affect maternal health outcomes and childhood development. Additionally, limited parental leave policies and inadequate family support structures create challenges for parents and caregivers, impacting their mental and physical health. Then we have health insurance coverage. Inconsistent or lack of health insurance coverage affects access to both preventative and emergency maternal health care services. While Medicaid expansion has improved coverage for many low-income individuals, gaps do remain, especially those who are ineligible for Medicaid or uninsured due to other barriers. This lack of coverage is particularly critical during the postpartum period, when many mothers lose their insurance, increasing the risk of untreated postpartum complications. Then we have mental health and substance use disorders. Untreated mental health conditions, again, such as postpartum depression and substance use disorders, can affect both maternal and child health. Lack of mental health support and stigmatization contribute to poor health outcomes and increased mortality risks, as these conditions are often undiagnosed and undertreated in vulnerable populations. Solutions to help improve these outcomes must be comprehensive and take into account these multiple factors. Next slide. Related to the social determinants of health factor that I just mentioned, and the importance of family support, fatherhood plays a really important role in perinatal health. The active presence of a father can help reduce stress, depression, and anxiety, as well as increase prenatal and postpartum visits and breastfeeding initiation and continuation, amongst other positive impacts. Hilariously, I recall when I was engaging in breastfeeding, my husband shouting at me, "Football, football, football." So yeah, I can sort of second the data on that. So fathers' contributions can sometimes be overlooked. As a former colleague that worked with the fatherhood program as part of the Healthy Start program once stated, We believe in a continuum of care, meaning that we want the father to be involved through the whole process, prenatal to the birthing process, to helping out postnatal and beyond. You can take a look at, sorry, next slide. Take a look at the list here. Some effective strategies and programs for father engagement are noted here, including important policy strategies like paid paternal leave and home visiting. I'm going to emphasize it again. Paid leave, not just paternal, but in this case, we're talking about fathers, paternal leave. We need to back up and advocate for the paid parental leave in general, let alone paternal leave and home visiting. Next slide. On the note of home visiting, that was also referenced by Dr. Franklin, an example of a program that has shown to be a best practice in terms of maternal mental health is Moving Beyond Depression. Moving Beyond Depression collaborates with home visiting programs to ensure coordinated care, allowing therapists and home visitors to work together in supporting mothers. The program provides training for home visitors and early childhood professionals to recognize and support mothers experiencing depression, enhancing that early identification, which is so critical for intervention. Research indicates that moving beyond depression leads to significant reductions in depressive symptoms, improved coping mechanisms, and enhanced maternal functioning. This specific example shared here is run out of Ohio, but Moving Beyond Depression has been successfully integrated into various states and regional home visiting programs across the United States, including California and Pennsylvania, demonstrating its adaptability and effectiveness in diverse settings. Next slide. Thank you so much for allowing me to discuss these really critical issues with you today. I look forward to hearing the other speakers and the Q&A.
Thank you so much, Dr. Bim, for setting this national context and for just helping everybody get on one page about the data and getting more knowledgeable about maternal mental health and maternal health more broadly. Really, really helpful data. For those who've been asking about the slides, they will be emailed out to everyone a few days after the webinar, so you'll get all of this information in your inbox. All right, so let's turn to the North Carolina team, the Guilford County team in North Carolina, and I'll hand it right over to Danielle DeShazer-Tabb.
So much, Ngazi, and good afternoon, everyone. I'm so honored to be here in the space and hear the panelists who came before me. It is just lovely to be grounded in my why again. I am Danielle DeShazer-Tabb with Ready for School, Ready for Life, and I'm joined today by my colleague, Brianna Grant from Every Baby Guilford. Together, we're excited to share how Roots to Ready is building a coordinated care network here in Guilford County that builds a village around families and connects families to essential resources of health, education, and social services. By streamlining access to support, Roots to Ready helps reduce stress, address basic needs, and promote overall mental well-being for families. We'll also share how we're working in partnership from a systemic perspective to help providers rethink how they serve families and how doulas are playing a vital role in supporting mental health and well-being during pregnancy and beyond. Next slide. So first, I want to share a bit about Ready for School, Ready for Life as a backbone organization here in Guilford County. Ready Ready is a collaborative effort to build a connected, innovative system of care for Guilford County's youngest children and their families. Next slide. Here is an economic snapshot of our county. It's a mix of rural and urban areas, but ranks in the bottom nationwide for economic mobility. Early childhood investments like Roots to Ready are a direct response to that challenge. Next slide. So our North Star is school readiness. We believe that healthy births, on-track development, and stable families start with coordinated care, and Ready Ready's work streams of Roots to Ready and school readiness is how we bring that vision to life. Next slide. So first I want to tell you a little bit about the challenges that we heard. In 2021, families shared that navigating support from birth to school entry was full of challenges. It was confusing, disconnected, and hard to manage. That's why Roots to Ready was created, to bring coordination and clarity to that journey. Today, I'll focus on how this coordinated care network is making that vision real. Next slide. So to address this challenge that families shared with us of feeling overwhelmed and unsupported while navigating services from pregnancy through early childhood, Roots to Ready brings together trusted programs to create a seamless, coordinated care network across the county. So that collaboration includes community navigation, which is based at Children's Home Society, and it connects with families prenatally in OBGYN offices and postnatally in a variety of settings. And then we have Family Connects, our home visiting program that's housed at the Guilford County Public Health Department, and it supports families at birth and hold strong relationships with local hospitals. Then we have Healthy Steps, also at Children's Home Society, and they work with families in pediatric offices from birth to age 3. And then to round out the collaborative, we have Nurse Family Partnership, also a home visiting program. And they work through Generation Ed, and they serve families who need more intensive support from pregnancy up to age 2. So you can go to the next slide. Together, these programs form the backbone of Roots to Ready. Working through an integrated data system, so that's the system they use to connect with each other, and it's supported by the community alignment team to ensure families are connected to the right services at the right time. This systems building work is primarily funded through the Duke Endowment and Blue Meridian Partners, along with other local and national funders. This work in Roots to Ready feeds into our school readiness pipeline. Next slide. I want to tell you a little bit more about Roots to Ready and our intake process. So families can enter Roots to Ready at any point, so through any of those programs I shared earlier. But many begin prenatally through community navigation in those OBGYN offices. During these visits, families are introduced to that coordinated care network. So they're introduced to all the Roots to Ready partners, and they give their consent to be part of that integrated data system. And they start with what's called a guided conversation. And during that conversation, they're able to identify any of their specific needs that the family might have. And that includes mother, father, a variety of family mixtures that we have. Roots to Ready is all about conversation and connection. So during those conversations, and this is multiple conversations over time, they're able to work in screenings like the Edinburgh or the PHQ-9 to help identify mental health concerns and inform referrals. Using the agency finder, navigators match families with the right services, and that can be mental health services, it could be material supports, a variety of things. As the person or the family goes into each of the Roots to Ready partners, they continue to have those conversations with families to build trust and continuously identify their needs, whether they be mental health or other needs that might emerge through that conversation. Next slide. While Roots to Ready centers the full family, we make sure fathers are included in a variety of ways. For example, we uplift father involvement with inclusive materials, advisory roles. We have fathers on our board. We have dad-specific supports and a family-centered approach across all of our programs. I want to share a couple of examples of how we have supports for fathers specifically. So you can go to the next slide. So here are a few examples of spaces dedicated to father involvement because we do feel that that's super important. On the left, we have Ready Ready's Fathers Ready to Grow group. And that's a safe space for dads to come together and discuss everything father related. They have a virtual space and they also do in-person events. And it really just gives them an opportunity to be in a space with other experienced fathers. And then on the right, we have an event from our community partner, the Peculiar Dad Network, who hosts a variety of dad-focused workshops throughout the year. So for example, he has, I'm going to be a dad, now what? We know new fathers need as much help as new mothers or new birthing people. And so he also hosts things like how to do your child's hair. I feel like that's an important skill that you're going to eventually have to learn. So we're excited to have different supports for fathers available to them. You can go to the next slide. So, supporting fathers is just one example of how Roots to Ready is committed to meeting the unique needs of each caregiver. But Roots to Ready is designed to support all families, regardless of who they are or where they enter the system, whether it's a first time birthing person, a grandparent raising a child, or a co parenting couple. Roots to Ready wraps around families with personalized, connected care every step of the way. Roots to Ready meets families where they are with personalized support and regular check ins to build trust over time. Roots to Ready partners connect families to long term relationship based programs, whether that's a Roots to Ready partner, a home visiting service, or doula services that you'll hear a little bit about in just a few minutes. And ultimately, Roots to Ready helps caregivers feel more confident, supported, and engaged in their care journey. And so we really want to build that village around families. Roots to Ready is just one part of a broader movement in Guilford County to reimagine how families are supported, especially during the perinatal period. That's why we're proud to collaborate with partners like Every Baby Guilford, who are leading powerful, equity driven initiatives like the community based doula program. While Ready Ready is a small funder in this work, we're honored to support a piece of the impact they're making. To share more about that, I'll turn it over to my colleague, Brianna Grant. Next slide.
Thank you, Danielle, for that transition. I am the perinatal health manager with Every Baby Guilford, and I'm excited that I get to do this work and speak on this work. So Every Baby Guilford is the infant mortality reduction strategy under the Guilford County Public Health Division. Our mission is to ignite and mobilize Guilford County through partnerships and unified strategies to eliminate racial disparities and prevent infant deaths. In layman's terms, that means we lead and support many initiatives. However, we cannot do this work working alone. We only can do this work working collaboratively outside of silos. Next slide. So Every Baby Guilford is a radically inclusive collective action movement. Collective action is a community-led process. That is a process where we go to community and ask about their needs and ask how can we help and support them. And then we go to funders to let them know this is how we can create a solution for this need, and this is where funding needs to go towards. And then we do that. We do that with shared decision-making. We do community listening sessions in order to gather this feedback and implement it in these collective actions and collaborative solutions. And so together we share the power, trust, and resources in a continuous quality improvement process. This involves continuous learning, continuous education, sharing of information, and data reporting so that we can best make sure that we're offering community what they desire and not what we feel they need. We've heard earlier about some of the data points related to maternal health also affecting our infant health, specifically infant mortality. What we do know is our Black and Brown families are disproportionately affected in infant mortality rates and maternal mortality rates. And what we do know is when we create a healthier Guilford County for our Black and Brown families that are disproportionately affected, we will create a healthier Guilford County for all of us. Next slide. One of our initiatives is the community-based doula program. And this is one that we partner with Ready Ready as one of our funders with. So what is a doula? A doula is a trained and often certified allied professional that supports individuals on their perinatal health journey. This particular community-based doula program provides birth doula services to clients referred from our partners. Regarding doula services in Guilford County, let's talk background. For over 20 years of the community, the YWCA of Greensboro has implemented a volunteer-based doula program model where they recruited individuals to be trained as doulas for reduced cost. In return for the reduced cost training, they provided up to 3 birthing people free birth doula services. Following that, in 2021, the YWCA in High Point launched a doula program using state funding. And different from the YWCA of Greensboro, this program contracted with 2 doulas, and they used a community health worker model and where they build relationships with maternal health staff. This program utilized this model to build on the collaborations, especially since it was new to this particular area that serves across 5 counties. Additionally, in 2021, the Cone Health Medical System also began implementing a volunteer doula program by offering a reduced cost training to individuals. In return for the reduced cost training, these doulas provided birth doula services to clients in the Cone Health Medical System for free. Now, the benefit is the Cone Health System created a registration process for doulas, and so it enabled Gifford County to collect information on the birth supportive services in Gifford County, and specifically Greensboro at the time. So with knowing all of that information for over 20 years, Every Baby Gifford began convening maternal health partners, doulas, and birthing people in a design phase group to create a countywide community-based doula program in 2021. The overwhelming feedback that we heard from our doula serving the triad was they attended reduced cost trainings and they wanted to build their own doula business, but they did not have the capacity to do so, nor did they have the resources to do so. And they were asked to provide doula services for free. And it isn't fair or equitable to ask someone to work for free. These individuals are the doulas that represent the communities in which we serve. So we knew that we needed to take this into account when building this community-based doula program. We partnered with YWCA of Greensboro, YWCA of High Point, the Cone Health System, and our Gifford County Doula Design Team to bring this CQR approach to this program to create the equitable opportunities. We launched in fall of 2023, and services began in spring of 2024, and we indeed hit the ground running. Clients receive birth doula services for free, and our doulas are compensated competitively as the program is funded by North Carolina Department of Health and Human Services and Ready for School, Ready for Life. Our independent contractors are required to attend additional training opportunities to expand their expertise and build on their competence and confidence. Next slide. What we do know is doulas do not directly impact birth outcomes in terms of they do not have control over doing so. However, research indicates doulas can significantly influence positive birth experiences, which can lead to better outcomes like reduced cesarean rates, shorter labor time, and increased breastfeeding initiation. Other statistics are found here and can also be found with a quick search. What we have found with our doulas is the guidance and perinatal care is associated with these positive delivery outcomes. And what we have learned is this program model work because we partner with home visiting programs and community navigation, and doing so offers a holistic approach to support the layered needs of our clients, who are those identified in underserved communities. Doulas are a piece of the puzzle. Next slide. It takes full collaboration on continuous quality improvement for us to see and feel the change in our communities. So another initiative that we offer to our perinatal providers is race equity training. Listed here are 4 of the types of trainings that we provided: groundwater in phase 1 provided by Racial Equity Institute, March of Dimes, implicit bias training, and critical foundations of reproductive justice. Together, these trainings touched on how to understand racism and really help practitioners understand the reality of us living in a racially structured society and what that causes in our health inequities. Our critical foundations of reproductive justice training allowed participants to receive a foundational understanding of reproductive justice and build the capacity and understanding that using the critical social theory. This initiative was funded by Gifford County Public Health, and we reached a total of 708 maternal health providers and counting. Next slide. Here is the what, so what, and now what of race equity training. The what is we knew implicit bias in maternal health care. As Dr. Franklin shared, we have researched the research a number of times. The so what was to offer implicit bias and racial equity training to healthcare providers, and we wanted to minimize the financial barrier to doing so. The now what is we partnered with Ride for Change management opportunities. The challenge we identified was staffing and also the time staffing needed to attend this required training. And the feedback that we heard from both Cone Health and the public health system was they needed a more hands-on approach. And so then after the now what, they needed to know what should they do now with having this knowledge and how to make them more aware of the challenges that exist. The what that we gave them, or the answer that we provide, is we continue to partner with Ride for Change with the goal that they will handhold each entity and through this process identifying strategies to ensure implicit bias is tackled. And we do this in the furthering collaborations and partnerships that we build. And should communities wish to build on this and replicate these services, I will pass it back to Danielle so she can elaborate. Next slide.
We just want to leave you guys with a few little nuggets. So for those looking to replicate work like Roots to Ready or to address deep-rooted disparities like Every Baby Guilford, it takes more than a great program. It takes a thoughtful process. You really need to assess community readiness, co-design with families and keep them at the center, build a strong collaborative backbone, and tailor the model to local needs. It's also important to invest in a data system, start small, learn as you go, and capture those lessons learned because those are all essential to long-term impact. Next slide. We thank you all for giving us an opportunity to share a little bit about our work. And if you want to learn more information, please feel free to reach out to Brianna or I. Thank you.
Thank you, Danielle and Brianna, so much for all of that information. Boy, there's a lot going on in Guilford County. They are very lucky to have both of your programs. So we're going to move on to a very quick question and answer panel discussion with our presenters. We know you all have lots of really great things to say. We're going to ask you, each one of you, a question and ask that you respond in 1 minute. So this is our challenge to you as we move forward through the webinar. So my first question is for Leah. And Leah, I'm just wondering, given your experience, if you could speak to policymakers and funders directly, what would you tell them? What would you ask them to do based on your experience?
I think I would say that we as healthcare providers and parents need to join with the communities that we live in and the surrounding communities to advocate for better access. And that's essentially why I'm here today. There are already organizations that are doing great work towards this. So I don't feel like a lot of times we need to create something. We just need to come together and work towards that. Because of our story with Daisy, that's the whole reason that I joined our state's perinatal quality collaborative, because it's going to take us all working together to find solutions to these problems.
Great. Thank you, Leah. Yes, this is a multi-system cross-sector issue that we must come together to work and to make better outcomes for birthing people and their babies. So Dr. Franklin, I'm going to move to you and ask, what do you see as the best way for practitioners within the systems to make changes to improve outcomes?
Well, a couple of things. One, I say drawing upon Every Baby Guilford's model. I mean, they really have, hit all those points in terms of a collaborative backbone, starting small, endeavoring to touch every pregnant person's lives. So, coordination with hospitals and really developing a system where there's no wrong door. I think, the secret sauce of it is in that structure. And you could see, I could see joy, abundance, affirming, not pity or paternalistic. It really is a beautiful model. I would add, depending on the type of provider or practitioner you are, if your only exposure to the folks that you are serving are the folks that you are serving, then that may be an indication that broadening connections and community is a beautiful starting place, and finding within your sphere of influence where you can expand your understanding, build relationships, and foster more joy and abundance through the work that you do day to day with individuals.
Thank you, Dr. Franklin. I so appreciate you bringing us back to joy and abundance. We can sometimes get caught in the negative in our work because there are so many challenges facing us. So thank you for continuing to bring us back to joy and abundance. I have a question for Dr. Bim, and it is about for the advocates and the practitioners here. What's one practical way that you feel they can build momentum around maternal mental health and in their own state or their community? So how can we serve these folks better? And what would you tell advocates and practitioners that they could do?
Thanks. I'd say that one practical way that advocates and practitioners can continue to build momentum is by partnering with community-based organizations, just like was described to us in Every Baby Guilford. Partnering with those organizations that have their ear to the ground, right, to raise awareness and normalize conversations around perinatal health, particularly perinatal mental health. They can put forth local campaigns, ramp up storytelling. As we heard earlier, the power of hearing from one person, their story, might be way more powerful than looking at a statistic, right? So ramping up their storytelling efforts, or encouraging community-based organizations to seek out individuals who are willing to share their stories, hosting community forums, having advocates really advocate for policies like Medicaid extension. I know that's maybe it's a little difficult at this time, but continuing to advocate for things like Medicaid extension, paid leave, and funding for maternal health and maternal mental health services, like not giving that up, continuing to advocate for those really important issues. Sorry, that was more than one way that advocates could keep these conversations going. But hey, I like to give options.
Lots of options. The more options, the better. Thank you, Dr. Bim. And I think Ngazi's going to move on to our next question.
Yeah, I'll pick up from there. So my next question is for Danielle. You gave us a really lovely framework of how the program in Guilford County works. I am curious, since you gave us a lot of information about ways that other communities can think about if they want to get started on this work, just some really helpful parameters for them to think about. Can you share some of the maybe pitfalls or issues that people who are trying to get started with this work might encounter? What might they face that you would already know, since you all have done this work, that you could share?
Absolutely. So Ready as a backbone, I think we've learned a variety of lessons since starting this work. I think the largest lesson for us as a backbone organization has really been to make sure that all of our partners are aligned with what community actually needs and keeping the family at the center. I think having continuous conversations with families in the communities, as you have those lessons learned and learning how to pivot, we want to stay on that common agenda, which is the core elements of, collective action. And so I just think it's super important that as you continue to implement and you grow and you expand, please continue the conversation with families and your community partners. You want everyone to stay on the same page.
Thank you. It's really helpful. And then, Brianna, we don't want to leave you out, so we've got a question for you too. So our question is, I heard a lot in your presentation the idea of building trust. And can you say a little bit about what you'd recommend to audience members who are trying to do this work, but are trying to build trust with families who have been historically underserved or overlooked?
Certainly. Thank you. That's a great question, actually. I would first start with going to where those families frequent and how they live, work, and play, like the social determinants of health. Research, the numbers and the data that you see in research is limited. It doesn't tell the full story. That is why a shared storytelling is so valuable. But if you haven't observed or really felt how different cultures interact, how they experience life, right, then you are not fully aware of the challenges that they are facing and the barriers that are present in their lifestyle versus mine as a separate individual. So I would definitely start by just really immersing yourself in that to your fullest capacity. So if they have a community event and it's called their cultural day or something as the sort, go and visit, have a conversation to make yourself understand or to start to understand how you can best approach a situation that is challenging that separate group, because you may know it's a challenge, but do they? So start with just building a friendship and a relationship, and then you can identify more.
That's, I think that's really doable. That's not a heavy lift. Thank you. I think because of where we are with time, we should move forward, even though I'd love to stay and ask you all more questions. So, can you move us ahead to the next slide, please?
So I'm gonna jump in here before the slide comes on, since we're running short on time. I just wanted to once again thank our impressive panel. You have brought us so much great information and lots to think about. And as you've seen in the chat and the Q&A, as you spoke and as you answered questions, more questions came up. And so we will do our best to get any questions that were left unanswered answered for you. We are, oh, here, look, thank you for joining us today. Someone asked for all the emails of the presenters. So when you get the recording and the slide deck, you will get all of these, all the contact information. We want to make sure that you've saved the date for our upcoming webinars. May 8th is, let's see, May 8th is our next one. And we're going to be talking about something that we don't talk about a whole lot, which is developmental environments, including extreme heat and the significant impact that it has on pregnant individuals and our youngest children. I also want to let you know that as you registered, some of you have put information in about innovative strategies that you would like for us to talk about, perhaps in another webinar or through a blog post or an interview on the exchange. Maine's doing some really interesting cross-sector work with their transportation folks. Nebraska's doing some great work with their child maternal mental health services. So we have heard you. We will be getting in touch with you shortly. So please don't think we're ignoring those, because we are not. Also would like to ask you to please fill out the survey. It's going to pop up just as soon as we close out the webinar. We really actually do read the feedback that you give us, and it will help us move forward and serve your needs increasingly better as we move forward. So thank you so much. Let's see, 3:29, not too bad. Thank you so much for joining us today. Love that you were with us, and we look forward on seeing you in future webinars. So everybody,
Thank
have
you
a
all.
great day.
Take care.
Bye.